Hello, everyone. I think we'll get started. Thanks for tuning in. My name is David Cook. I'm the Director of Emergency Ultrasound at Roper Bon Secours St. Francis Hospital in Charleston, South Carolina. Today we're going to be talking about starting a point-of-care ultrasound program. This discussion is something that really has a lot of points that are germane to any emergency department, certainly other departments within the hospital, but I think there's going to be a great deal of this discussion that will be particularly relevant to community-based practices and so forth. But as I said, there will be some points that we can discuss that will be relevant to just about anybody looking to start a point-of-care ultrasound program. I think there's a lot of question when trying to delve into something like this is just where do you start when building a program such as this? And I think in most cases, there's probably something already in place. I envision quite a few folks that are arriving maybe at a new job, tasked with starting a program or looking to build a program, probably have certain elements such as an ultrasound machine that may already have been purchased and already in the department. It may be a relic, it may be parked in a corner and hardly ever used, but there may be one actually there. There may be some other elements of a program in place, perhaps a pathway for quality review. Certainly, I would guess some sort of pathway for credentialing, albeit maybe a very rudimentary one. When looking at things, that's a great place to start and say, what do we have? But you need to develop a vision and you need to understand where you want to take a program. And so certain things become important beyond that. Are there expectations of a program, both within the department, within the hospital system, from administration and so forth? Who are the relevant players? As I just said, administration, your colleagues, other specialists. Are there barriers to developing a program, be they colleagues that are disinterested, be they specialists that are from other departments that are wary of the use of the technology in the emergency department, or financial barriers. And then ultimately, looking at all of this, what do you want in a program as a department, as a director, and how do you build that? And these are the things that we are going to touch on today during the next several minutes. So again, looking at where do you start, there are going to be resources and things in place, credentialing and training, hopefully some element of that or some pathway for that that's already been established, likely a machine. And then what else do you have? Do you have a workflow process? Is it thermal images and photocopied QA sheets that are in a file drawer? Is there some electronic process in place? With that workflow process, is that a QA process as well? How are you retaining images? How are you QAing images and so forth? And then are you billing it and or somehow generating revenue from this process? As I kind of say, I think at the bottom of the slide I reference hitting the ground running, and I think that's a good way to think of this is when you get on the scene, there are going to be certain elements that you have, and just plan on trying to work with that because you will have difficulty building a lot of things very quickly because of some of the constraints that may be there. So take what you have and make the best of it, and try to form a program off that with plans to build or remodel, or however you plan on envisioning your program taking shape. The big thing that I think a lot of early programs lack is a QA process. Hopefully there's a credentialing process, but the workflow in general, the credentialing, the QA, the general workflow, image retention, and so forth tends to be lacking. I think a lot of places have a machine, they use it, and there's no back-end accountability, for lack of a better word, for how that program is run. And I think that's something that needs to be put in place quickly and not necessarily elegantly. That's something that could be done on a fairly rudimentary basis just to meet basic needs. Again, as I said before, there's probably going to be an ultrasound machine in place in your department. Purchasing a new machine is something that is going to be take some time. It's going to take some time to get there. You're not going to have necessarily the revenue or the capital to do that right away. And so sometimes using a machine that may not be your first choice for the department may be necessary for an extended period of time, sometimes several years. Hopefully not, but be prepared to do that. And my final general broad tip in terms of getting off the ground is to forget billing for a while. It's great if you can do it, but I think billing brings upon the program a fair amount of scrutiny from various folks within and outside the hospital. And so you want to make sure that you have a rock solid program before you start to bill. And I am not a fan of jumping into that quickly until you really have met all of the above prerequisite issues first. And so I would table that possibility for probably a little while until you can get things off the ground. In looking at the players and building things, you need to look at what the hospital's commitment is. You will find that there will be various parties within your department and the hospital that are very interested in building a program, and then quite a few that probably are indifferent or uneducated perhaps. They don't understand the importance of having a program. They don't understand the nuances of building a program or the requirements of maintaining a program. And so hospital commitment will vary and may require some rallying of the troops and some education of various parties to make sure that they're up to speed on why this is important, why it needs to happen, and why they need to be motivated to help make it happen. Looking at that, you probably won't have much budget initially unless you're stepping into a role where you are being sought out to do this and to get this off the ground. There may not be a lot of capital to get things running. And so be prepared to not have a lot. A shoestring budget is not unusual as this process starts. And then looking within the hospital, do you have a lot of organizational support outside your department? I am a huge proponent of involving IT and building a process, a workflow process. I think they can be incredibly important and incredibly helpful. And I think they're oftentimes the unsung heroes in building a workflow process, because they can take so much of this process and automate it and digitize it and move it into the background that takes it off the plate of the physician who's performing exams. And so I think early involvement of IT and heavy involvement of IT, if you can find some motivated folks within your IT staff to help, is incredibly important and helpful. And then within organizational support, I think you have to look at other specialties, certainly other specialties that use ultrasound, OBGYN, cardiology, critical care. But the big user of ultrasound is radiology. And what is the relationship with radiology within your hospital? Are they supportive? Do they understand the goals of a point of care program and how it affects them, how it can benefit them, and so forth? And so that's a critical role, because they will have a large voice in the imaging services realm within the hospital system. And it's good to know what their feelings are on it. And I think it's good to find some people within the radiology department that are interested in helping build a win-win program that can help them and also help the emergency department. But be prepared. This is a slow process. Oftentimes there is very little interest from the hospital system in general. There's often very little budget, and you need to take the time to build these things. It can take a lot of meetings and discussions and so forth, but it's worth it. And definitely don't expect everyone to be on board very quickly. There's a lot that can go into building a coalition of support to get things off the ground. Within that realm, hospitals' expectations are going to be variable, and there are going to be certain things you need to think about. People coming to you asking you to do this, or if you're going to them and asking to get a program running, they're going to have some demands or expectations. One is a time frame. They're going to look to have this done in a certain amount of time. Certainly, if they're coming to you and asking you to get this off the ground, do they have a realistic time frame, and do you need to adjust that time frame based upon the other factors that go into how quickly you can build things in terms of capital and other resources? And so understand what the time frame is, and understand if you need to perhaps adjust that. With the hospital, do they have a sustainability expectation? There will be some departments where there's a goal that a point of care ultrasound system generates revenue. There will be others that say it doesn't necessarily have to generate revenue, but it shouldn't cost anything. So it at least needs to generate enough revenue to sustain itself. Those are things that you need to know, because that definitely helps you frame how you're going to go about doing things. And then, are there any constraints? Are there things that you can't do? We have a nice guideline within the emergency ultrasound section in emergency medicine of how to run a program and things that we can do, but that doesn't necessarily mean that every hospital will allow all of those scans to be done, will allow the program to be run to its fullest capacity. And so are there constraints that you need to be aware of that are non-negotiable? And again, those are all key elements to know to help frame how you're going to build a program and the goals that you're going to have and the time frame that you're going to use to build that. And so you need to know all of those things. As far as other players outside of hospital administration, the big one is, or the big group is to keep in mind are your ED colleagues. There will be several realms of colleagues. There will be folks who are credentialed. Hopefully those are people that you can turn to be super users and physician champions of a new program. Those will be people that you can lean on perhaps to help grow the program and to cheer its successes to others. The non-credentialed folks, hopefully there will be some motivated folks within that realm, within that group that are interested in pursuing credentialing and getting things running quickly, because increasing usership and getting those folks off the ground is one of the key successes of a program. Within that same group of people, you'll have interested and disinterested people. And I think we equate credentialed with interested and non-credentialed with disinterested, and I don't think that necessarily lines up. There will be some credentialed folks that don't really feel compelled to use the technology often, and there will be some non-credentialed folks that are very motivated. And I think those are people to tap into, temper their expectations, and make them understand that it's going to take some time before they can become credentialed and start to use their abilities for clinical decision making. But that's a great group to tap into. But the credentialed interested folks are really that super user group that I think you need to identify and find early, because they will help you to grow the program. Your IT department, I'm going to start to sound like a broken record on this, because I just feel they are so important, and that comes from my own experience, and I'll visit on that with you a bit later in the discussion, because I'll show you some of what we've done in my hospital system. But IT has been critically important, and they are so helpful. And so I think identifying who within the IT department might be available to assist early on in the process is very, very important. And then within radiology, again, I think finding a point of contact or someone within radiology that's interested in working to help build the program and help shepherd this through their realm is good as well. I think there are the stereotype is the horror stories of radiology resistance to point of care ultrasound, and I don't think that's necessarily always the case. And so I've been blessed to be in a system where we have a great relationship, and radiology has been very helpful to us in building a point of care ultrasound program. And so, but that's good to know who is going to be helpful within imaging services in general to help build a program, and are there any roadblocks or any things any items that you need to address with them to allay their concerns or to meet certain criteria. And I should say, when I say radiology, really I am referring to radiology, but on the broader scale, imaging services from an administrative level, because they will have concerns regarding image retention and issues such as that the hospital feels are, as I say, kind of non-negotiable. Basically, they may say, we want all image retention to be done on in-house servers. We are not interested in, or we are not comfortable with a solely cloud-based image retention system, or we ask that you use this pathway in order to generate your studies. And so those are good things to know. If you can't identify those people, if you can't find the allies within various departments, including your own, that are going to help you, it really does limit how quickly and how successfully you can build a program. Again, just to review, I think interest amongst colleagues is quite variable. And when I say colleagues within the emergency department, or whatever department you are functioning in, I'm a big fan of the super users, because I think that they can really help tout the technology, tout the benefits of the technology, tout those good cases. And with that in mind, I think you have to make the most of opportunities to go to the skeptics within your group to show them the benefits of point of care ultrasound, how it can help them, how despite the fact that they may have practiced for 20 years and have their practice patterns well established. You can add some new flourishes to their ability to evaluate a patient, some new skill sets that they can use and make their lives better, increase the satisfaction of the patient, and increase patient safety. And I think this is one of the big ways to do that. And it's funny, it's so simple, but vascular access, and not even really central line access. This is just peripheral catheters. It's funny how you can win folks over with this. We've reached a day and age in medicine where the typical peripheral IV is not a simple thing to get. And so when you can go into the department and find a colleague that has a patient with difficult access, and they're thinking about whether they need to place a central line or do something further for access, and you can go in and say, I can place an ultrasound guided IV for you. Here, come with me. Let me show you. And you go in and you establish access on a patient that was otherwise going to be a real pickle for them. They look at that and they say, thank you so much, and then can you teach me? Or my favorite is when you do that for a colleague and then you come into the next shift with them and they say, oh, I wish you had been here yesterday. I had this patient. I just couldn't get I couldn't get a line on them. I wish you'd have been here. And that's an opportunity to say, I'm sorry I wasn't here, but I can teach you. I can show you how to do this. And I think, I joke, I think peripheral IV, ultrasound guided peripheral IVs are our gateway drug for point of care ultrasound, because I think we can get a lot of people hooked because it's so simple, it's so readily needed anymore in our practice that we can get people very interested quickly, and it's a fairly simple thing to teach them with respect to some of the other applications that we can teach for ultrasound. And so I find it to be a handy tool to help win folks over. A few other things that I use, certainly echo, whether it's in a code situation or some other situation. I've had some successes with colleagues who have patients that appear to be that are dyspneic patients, and there's a question of whether perhaps this is CHF versus some other cardiopulmonary issue, and they're not a patient that's been seen in our system, so we don't have an old echocardiogram, we don't have a lot of records, and I can go in and do a quick bedside echo and give them some idea of ejection fraction, of left ventricular function, or we can look for signs of some other sign of volume overload, be it on thoracic ultrasound or echo. I think that's very important, and it's one that typically involves a fairly critically ill patient and gives them very usable, rapid information that they can use to help manage these sick patients, where sometimes seconds and minutes are particularly critical. And so I find that echo is another good tool or good modality to use to win folks over. Another one is fast, and I think we take this for granted, those of us that have trained in the day and age of fast exam for trauma, but the reality is a lot of folks practicing emergency medicine still have not trained in that modality, and the ability to go in on some trauma patients that perhaps have some possibly labile vitals or some other questionable finding, and say, listen, I know you're going to get a CT scan, but would you like me to go in and do a quick fast exam on that patient? Why don't you come with me? We'll do it together. Another way to win folks over. I think any ultrasound modality has the potential to win people over by saving the provider time or providing critical information in critically ill patients. But these are just a few that I've found are valuable that people will ask me to help them with when they aren't necessarily credentialed in the modality. The final thing I think you do is you tout good cases. This is one that I had recently. This is a patient that was obtunded, actually, and we thought had cardiomegaly on their chest x-ray. It was a fairly poor chest x-ray, and we went in the room and there was we were suspicious that it was either cardiomegaly or a pericardial effusion, and in fact what we found was this very large left-sided pleural effusion, and so that changed our evaluation fairly quickly, and this is one that I pulled some colleagues in and said, hey, look at these images. This is a great case. This is something, this helped us. We changed our decision making based on this study. We had another case recently one of my colleagues performed a bedside echo, or sorry, not a bedside echo, a bedside aortic scan on a patient who had suspicious signs and symptoms for a AAA, a ruptured AAA potentially. We did in fact detect a very large aneurysm, and there were several sonographic signs of rupture. That patient was headed for the OR with a vascular surgeon on the phone within about 10 minutes of arriving in the emergency department. And so that's another good case. We pulled that study up and showed as many people as we could in the coming days to say, look what this technology can do. Look how this helped us. Look how quickly we dispositioned this patient who not only had a AAA, but had a rupture. And this was a life-saving intervention. And again, that wasn't my scan. That was one of our, again, super users, one of our physician champions. It was a credentialed user who was kind enough to tout that technology to others and say, boy, this really helped me. And so you win people over with studies like that. And that's something that you can do to help build that support, or certainly win over the skeptics. So take advantage of those opportunities when you can tout the technology, because it really does, I think, help make a difference and win people over. It's easy to tell them, hey, you need to be doing ultrasound, but when you can provide them tangible benefit and show that to them, or help them in their own practice, or help them out of a bind, as it is sometimes with vascular access, I think it's a very nice tool to help grow the program. Again, this is my broken record message. Continue to involve IT. They are the unsung heroes sometimes of the workflow process. Again, identifying how you're building the program. We're still working through how do you assess the ground rules as you're building your program, and you look at what are the barriers. And I think from all of the things that we just discussed, you've identified your barriers, whether it's skeptics in your group, whether it's other departments and relationships with other departments, whether it's financial limitations or time frame. You establish what are your barriers or what are your constraints, and that helps you identify how you're going to build your program. I think the dream scenario we all have is to walk in the door with a carte blanche, blank check, and no system, nothing on the books already that you can say, I want this machine and I want this workflow system and I want this to be our process. Everybody says, that's great, let's make it happen, and you can do whatever you want. And all the other departments say, sounds good, let's do it. And the reality is, you're not going to have that. You're going to probably have a machine. IT hopefully will be able to help you. There may be the request to use systems that are already in place, for instance, a PACS system or something to the contrary, to the contrary of your own wishes or desires for the program in order to retain images and so forth. And so you have to be aware that may come down the line at you. Administration will probably have some requests on how the process runs and how the program runs. And administration being imaging services, possibly the emergency department in general, there will be some constraints. And then other departments will have concerns. And I think you have to have a plan to address those things. Certainly when it comes to imaging systems, PACS often is requested to be used. And I think there are some limitations to PACS for an emergency department, mainly the ability to QA non-credentialed studies, to parse credentialed versus non-credentialed studies. And you need to look at some of those things and have those answers ready for when somebody comes to you and says, we want you to use PACS. We're not going to use another workflow system. We want you to use PACS. You have to have those answers and those reasons ready. When other departments come to you with concerns, you have to have a plan to help appease them or meet their needs. We've had early on an OBGYN came to us and said, I like that you guys are doing these the pelvic ultrasounds in the emergency department, but when they come see me a couple days later, I can't see your images, and so it would be very helpful to me to be able to see them. And so the answer there is we get them access to our image retention system so that they can see those. What we've done since then is to build a process where those images are retained on a central site that anybody can see them within the hospital system, that they're in a PACS-like environment called a vendor-neutral archive, and I will come back to that in a little bit. So, how do you do this? As you get on the scene and you work with what you have. You say, this is my machine for now. This is the process we have, or I'm going to build a very rudimentary process to meet the needs, the very basic needs of a point-of-care ultrasound program in the emergency department. you identify your allies within IT, within your own emergency department colleagues, within administration, within radiology, and you work with them to help make the program happen. Find the strengths that you have, because there will be good things about the way you can run things. Maybe it is those relationships. Maybe it is IT. Maybe it is a great budget that you can go out and start to buy machines and do what you need to do. But find those strengths and capitalize on those very quickly. And then when it comes to other departments, find win-win situations, find win-win opportunities. As I said, with our OBGYN colleagues or critical care or somebody else, if they have concerns, find a way that you can show them that the technology can help them too. And it can, and they just need to be able to see that, and they need to have a pathway to be able to benefit from it. I think that there will always be naysayers, obstructionists, if you will, and I think the key there is to highlight the fact that point-of-care ultrasound has significant benefits to the patient with respect to patient safety, certainly procedural guidance and so forth with ultrasound in the emergency department, central lines and so forth, patient safety, the ability to glean critical information very quickly in critically ill patients is a patient safety issue. There's patient satisfaction benefits. There's administration satisfaction benefits when it comes to increased throughput, because we can do things faster at the bedside. And so when you hear people saying maybe this shouldn't happen, be prepared to just come back and say, no, it needs to happen, and this is why. And then win people over, winning hearts and minds. And whether it's your colleagues, showing them how you can help them, whether it's your colleagues in other departments by showing them how we can get these images and send them to them. Perhaps your cardiologists want to see your bedside echo when you admit them a patient that they've never seen before, and maybe it's a CHF patient or something further. Find ways, if they want these things, find ways to make them happen, because once you build a robust digitized system where you're retaining images digitally, which is the goal, I think, in the long run, you have the ability to do things like that. And once you've done those things, start building your program. I think go back to what we've just talked about: credentialing, training, the machine itself, workflow, documentation, and QA, and start to build that program within the constraints that you're given to meet the needs that you have. Don't forget about the emergency ultrasound section. In emergency medicine, this is an incredible resource for us. And a lot of what I'm talking about here is present in various guidelines and white papers and so forth on the section website. If you're not a member and you're building you've suddenly become the director of your department, I think this is a great. It's worth the money to join the section. And I won't go into all the available support that's there, but it is abundant and wonderful. And within the section as well, there are people that have done all of the things that you're going to be doing. Take advantage of your colleagues, because they're wonderful resources and knowledgeable folks that can help you and guide you along the way. With respect to building credentialing, as I said, hopefully there's already something in place when you arrive on the scene, or as you're building this, or if you're building it from scratch, you need to get things off the ground. There are ACEP guidelines for credentialing. If you're residency trained in point-of-care ultrasound, you get a letter from your residency that you've met all of the required elements with respect to RRC, training and ACEP guidelines, and that should be sufficient to submit to your credentialing body to get you credentialed. If you are not trained in, or not residency trained in point-of-care ultrasound, you need to accomplish a couple things. You need to have 16 hours of formal training that generates CME and conforms to ACEP guidelines, and you need to have 25 scans per application. And then you need to decide how are you going to run your credentialing? Is this going to be an all or nothing credentialing process where you submit for credentialing when you've met 25 scans in all of the relevant applications, and then you are credentialed in everything, and until then you were credentialed in nothing? Or are you going to do an a la carte type credentialing process where as you get 25 scans in certain applications, you can submit to be credentialed in those individual applications? I'm a big supporter of the a la carte. I think certainly in the community setting, I think as particularly, I have colleagues that say, I don't need to do certain things. I'm not really interested in right upper quadrant ultrasound. I'm not interested in pelvic, but I really would like to do aorta. I really would like to do echo and fast. Can I just be credentialed in those? Because if I have to do all of these other things, I'm probably not going to do any of them. And so I like the a la carte, because it gives you I would much rather have somebody be credentialed in a few things than have them sitting on the sidelines, possibly never to become credentialed, because there are one or two types of scans, of applications that they are just not interested in. With respect to the training, you can do one of two things as you build a program. You can develop a homegrown course. You can build this all yourself. I think that's really labor intensive. It takes tremendous. Well, among other things, you have to be able to generate CME from your training, and I think that alone is a fairly laborious task. And so, the established courses that are out there are great. There are several varieties of courses you can do, as they say, the import course or an on-site course, where there are companies that you can hire to come in and run the course in your department, get all of your folks trained at once, or the export kind of destination courses where they'll run a course in Hawaii or in some other nice destination that you can travel there individually or in small groups within the of physicians within your group and take the course. Do whatever works for you. But I think definitely the established courses gives you a little bit better option with respect to that. The ultrasound machine, we've talked about, you probably are going to have one. I hope you have one. If not, I hope you have a budget to get one. But be prepared to use it for a while, but be ready to move forward when you're allowed to. In our department, we had a 2 to 5 year plan to keep using the machine we had, and we didn't really know when it was going to come around to get a new machine, when that time was going to come. And very quickly, after a couple meetings, word came down, let's go get some new machines. And fortunately, we had our ear to the ground and had been following developments with various manufacturers and tracking some systems that we liked. And so we were able to go and contact a few vendors very quickly and say, can you come in? Can we demo your machines? We'd like to make a decision soon. And so it was helpful to be at least tracking the market and tracking the technology a little bit from the periphery. When you're looking at a machine, keep in mind the complexity of the instrumentation. In the community setting or any other setting, there will be a lot of folks that are scared by the knobology, if you will, the interaction with the machine. How many buttons do they need to know, basically? I've had folks say on very complicated machines, just show me the 5 buttons that I need to use. Well, sometimes if there are only 10 buttons, it's easier to show them the 5, at least to get them off the ground. The goal is to get people very comfortable that they can start to optimize their images through and use the full capacity and the full potential of a system. But certainly there are folks that just get intimidated right off the bat by what they see on the user interface, and that's a problem sometimes. So keep that in mind as you're looking at systems. And then the other thing that I think is really important now is the ability to keep the front end workflow on the machine. Do you want a system that allows you to perform the scan, document your findings, and end the exam all on the machine and walk away to another task? Or do you want a system that's going to require you to potentially log into a web terminal to document your exam and perform 2 or 3 tasks away from the bedside after you've completed the scan in order to complete the front end workflow? I think we're all very busy folks. And so if you can keep that workflow at the machine, at the bedside, folks will be more likely to use the system, and that increases your likelihood of having a successful program that people will adopt. With workflow in mind, understand that there are some things that you need to do. Workflow needs to address two groups of people. There's a workflow need or a workflow system that has to align a certain way for the emergency department, but also then for the hospital in general. And there are some issues and nuances with both of these that kind of have to reconcile with one another. This is my broken record message, where IT is really, really helpful because you can automate a lot of this and do a lot of this in the background that the user at the point of care doesn't have to think about, and it makes this a very seamless process. I'll come back to this later. This is the workflow that we have in my department. I will just highlight the number of arrows and the number of things that go on, and I will show you in a little bit how this works, and then I'll show you what the actual user has to do at the bedside. But this is the complexity that you can build if you have an IT department that is able to do this for you and to digitize this process and automate this process in the background. So I said there are kind of 2 groups of needs with workflow. There's the emergency department program needs, and then there's the hospital needs. The program is going to need efficiency. Your colleagues don't want an 82-step process that's going to take them a lot of time. They're very, very busy people. This ultrasound that they're going to perform is one of a number of tasks that's on their immediate list of things that need to get done. And if you make this process too complicated, they're not going to do it. Hence the ease of use need. You need the workflow to route and store these images for QA review. Certainly for your credentialed colleagues, just for image retention, and a QA review of part of their studies, or as much of them as you deem necessary. But for your non-credentialed folks, you need to route those and store those images so that they can be reviewed for credentialing purposes. You need 100% review of those studies, and you need to be able to review and track them to march out their progress toward credentialing. And so that's a need of the emergency department. The ability to parse credentialed and non-credentialed is really critical, because you may use your workflow system to route credentialed studies onto a permanent repository, whereas your non-credentialed will be kept native to your workflow system in the emergency department. But that's a critical need, and that's a common one that's shared with the hospital, the need to parse credentialed and non-credentialed, because the hospital is looking at it as saying, certainly if billing is going to occur eventually, we don't want to bill for non-credentialed studies. We don't want non-credentialed studies to show up anywhere in a medical record, because they're not part of the medical decision making. They're not part of the medical record. They're training studies until that user is credentialed. They need the image retention as well, but they need a couple other things. They need the ability to verify and correctly identify patients. We can't have typos in entering a patient name that suddenly dislodges that study from the patient's permanent medical record. We need that to be a very accountable, verifiable process. And then there needs to be accessibility of the imaging, because the hospital, and again, your colleagues in other specialties, are going to want to see those images. If you're calling a surgeon with concerning findings about a AAA, they probably want to see that ultrasound. If you're calling the OB, they probably want to see your pelvic ultrasound. And so you need to have some accessibility beyond the emergency department, and that's a need that you have to address with workflow as well. So efficiency, ease of use, and that ability to parse credentialed and non-credentialed, I think, are really the keys, are key points that you need to keep in mind from a program success standpoint as the ultrasound program director, because your increased usership amongst your colleagues is going to determine how successful the program is. Efficiency and ease of use, if they're not there, will drive people away, because it's just too complicated of a process, especially for a novice user. Think about workflow on the front end and the back end. On the front end, for patient data entry, remember what I said, you need a verifiable, kind of trackable and robust process to make sure that patients are being correctly identified, be it by medical record number, accession number, or whatever identifiers the hospital requires. And so are you going to do that via order entry and a modality work list? And I'll come back to what that means in just a bit. Are you going to use a barcode scanner to scan the patient's bracelet so that data gets entered? Or are you going to use manual entry, which is the most error-fraught possibility, because then you're relying on the user to punch in the exact correct numbers in the medical record, or spelling of the patient's name, or whatever you're doing. But again, that's the least robust way of doing it, and sometimes that's just what you have to do. Perhaps there's not the support within IT to do it any other way, but you have to decide how you're going to do that. The front end then is just a matter of executing the scan and then transferring the study to the back end of the workflow process. And then at that point, you're going to complete the study report. You're going to generate some sort of document and retain the images and QA review them. But that patient data entry is so important, and I think you need to think about how you're going to do that, and how, again, robust a process that's going to be. And when I say robust, really from a hospital standpoint, but easy from the user standpoint too. The quicker that process is, the better it works for everybody, and I think the more people will use the system. From documentation, we had talked about this a little bit earlier in terms of, can you document on the machine? Can you document at the bedside? Your documentation needs to capture certain things. Are you going to capture the relevant data that, obviously from the study? You want the images, you want the findings, and so forth. If you're going to bill, you need to make sure you have the adequate items in documentation for billing. You need an indication, you need your findings, you need at least an image, if hopefully multiple, but at least an image. From a location standpoint, in terms of your documentation, is this going to be done at at the bedside on the ultrasound platform, on the system itself? Is this going to be done in the EMR after you've completed the scan and you walk back to whether you have an EDIS or an enterprise system, whatever documentation system you're using? Are you going to just document it straight into the medical record, or are you going to document it on third-party software? Are you going to use a web portal or something that you document in some other software and go from there? I think that as much as you can, keep things at the bedside. QA review really has a number of points you have to keep in mind. Your QA needs you need to be able to review the images to provide feedback to the users, and then to track the credentialing for the non-credentialed users. Ideally, if you can find a system that tracks and then flips a switch when they've met their 25 to alert that they're ready to go submit for credentialing, that's great. The more automated the process can be, the better. But that's what you need to have at a very basic level out of your QA. But you need to decide, is this going to be a remotely accessible cloud-based system? Is this something you need to think about from a QA standpoint, your documentation? If you are performing the studies and retaining the images at one place and documenting in the EMR, to QA review, you need to sit at a terminal that has access to both, and you need to be in two systems in order to get everything married up so that you can read the findings that the user had and pair that with the images that you're seeing. And so using a system that marries all of that together in one place is I think, I wouldn't even say very helpful. I think it's absolutely necessary. I think it's very difficult to provide QA when you have that kind of system. It just becomes very labor intensive. And then you need to look at your QA review or your QA system and say, is this going to serve some additional purpose? Is this going to be your only image repository? Is this the only place these images are going to reside within the healthcare system? Or is it going to route to a PACS system, to a vendor-neutral archive, or to some other secondary site where it will be retained either primarily or in addition to your QA site? But those are the key things. The QA needs are fairly static. These are the things you have to have from QA. The things that you need to think about in terms of when you're building are these points that I've highlighted on the right, which is how are you going to do this? Remotely accessible is great if you can do it when you're not actually in the department. It makes QA review a lot easier. And then looking at the rest of the process, some of that's going to come back to what the hospital requires of you. They may say, we're not comfortable with the primary image repository being your QA system. We need it on our local servers, which is what my hospital system said to me. And actually then they presented a very elegant solution, which I will come back to right now. This is our system. This is our process. And this is by no means the only way to accomplish this, but I wanted to at least show you how this can be done, and to drive home my message that I've been saying throughout this discussion about IT. This is something that IT built for us. I would love to take credit for what you're looking at, but I had very little role in this process because IT and our Director of Imaging Services and a few other folks came together and said, listen, we can build it this way. This will work great. This will meet everybody's needs. And we sat back and said, fantastic, this is great. So this is how the system works. We have our EDIS. If you start up in the upper left-hand corner, we use an EDIS rather than an enterprise system, but you can have either. When we want to do a bedside ultrasound as a credentialed user, we place an order in the EDIS to do a bedside ultrasound. That order passes through our health information system or our enterprise system, which routes that order to our radiology PACS system. This is the only time we use radiology PACS. We don't actually retain images on them, but radiology PACS populates a modality work list on one of our ultrasound machines, and we have 4 emergency departments in our system. It sends, depending on where the order is placed and for which patient, it routes to the appropriate machine in the appropriate department and populates that patient onto a work list. The user then goes and queries the list, finds their patient, selects that patient, and performs the study. When they do, they then document. Our system allows a documentation on a worksheet at the bedside, so they complete the entire worksheet while they're in the room with the patient. They end the exam, and they're done. The user is done at that point in time. The machine then, via wireless connection, uploads the study to our workflow system, which is our QA system. It also serves as a gateway for us to route the study beyond the workflow system. So Our non-credentialed studies stop at that point. That blue line is a wall. Nothing passes beyond that blue line if it's a non-credentialed study. If it's a credentialed study, it routes to two places. We have a vendor-neutral archive. And a vendor-neutral archive is kind of like a PACS system, but it allows retention of various medical imaging, various other medical information. In this case, it can store both our image or our images for the study, as well as the PDF report of the image findings. It can store a lot of other things. VNAs can store EKG imaging, medical photography. There are lots of things that a VNA can be used for, but in our case, we're using the VNA or a portion of our VNA for this, and so that's our final image repository, and it's queryable by anybody, any other physician, any other specialist. If they want to see our studies, they can go to the VNA and get that. It also routes that PDF report back to the patient's medical record in their not necessarily in the EDIS record, but in parallel to the EDIS record within their long-term medical record. They have now a copy of this report. It's not within the radiology documentation. It's its own separate folder, and it exists there. And so that's also queryable by anybody who's reviewing the patient's medical record, any other specialist. And that's how this all routes. The back-end workflow for the point of care, for the ultrasound director, then is to go back into the workflow system, pull that same study, which is also retained there, and perform QA review, provide any feedback to the user, and certainly then to provide QA review for those non-credentialed studies that stopped at that wall, that didn't pass beyond the workflow system. The only other wrinkle for the non-credentialed users is that there is no order for them because it's not yet a credentialed study. They actually go in and manually enter the data. This is what it looks like for the user. They have to do a couple things. For the credentialed user, they enter an order. For the non-credentialed user, they manually enter the patient's name and their name so that we can identify who performed the study. They then go perform the study. For the user, that's the credentialed user, they pick the patient's name from the work list, they complete the study, they complete the worksheet on the machine, and they end the study. And that's it. The user is done. The physician who's performing the study is done at that point in time at the bedside. Everything else happens in the background. The only other thing that the emergency physicians do is the emergency ultrasound director, me, goes in and then pulls up the study and does QA review afterward. And so it's a robust automated process, and the ability to enter orders, make sure that the patient information is routed correctly, that there are no misspellings, that there's no error there, and everything happens in the background to deposit the imaging, deposit the report in places that are readily retrievable by anybody else outside of our department that wishes to see it. It's a great system, and we couldn't have done it without IT. And so I'll start at the bottom of my final tips and perspectives, which is involve your IT staff. If they can help you, if they're available to help you and willing to help you, they can do so much that we just don't understand. I've learned a lot from them through the process of building our system because I didn't know what a modality work list was initially. I certainly didn't understand how orders routed through our system. And I've now learned this is the way all of our orders route, but I've learned a lot about IT. And so, but I couldn't have done this, or we couldn't have done this without them. They really have done a lot of the heavy lifting in our process, and it's been awesome to have them on board. But to go back up to the top, I said this before when talking about the emergency ultrasound section. Don't reinvent the wheel. You have people working for you within our section, within our specialty. They can help you. They can help you through this. They can shepherd you through the process. They've done this before. Whatever you're doing, somebody else has already done it, and lean on folks to get their perspectives. Build that user-friendly process. Increased usership is so helpful. If you build a complicated, difficult process, people just won't pick up the probe. And so minimal steps, make it easy, pick a machine that has a good user interface that people will be comfortable with, and maximize how much that process happens in the background. And then take as much as you can of that process and put it at the bedside. If you can do that, people will be much quicker to use the ultrasound machine and perform the scan. The reality is we're all busy people, especially in a shift. There are so many other things going on around us. If the process is too complicated or requires too many different steps, it's just easy to not do it. And so make it quick, make it easy, and you'll find that people will be much happier picking up the probe and using the system. And so with that, I'd be glad to take any questions. I thank you for your attention. It's been my pleasure to talk with you today.